So let's start. Hi to everyone, my name is Neofytos Mavris, and currently I'm a resident in the Department of Ophthalmology in Hadassah Medical Center in Israel. Today I will give a lecture on the adverse events of AMD treatment medications after FDA approval. So I will start with a case presentation. It's about an 80-year-old male patient, pseudophakic in both eyes, that has been on regular follow-up in our retinal clinic. And here we see a fundus autofluorescence photographies on both eyes, and we can observe that the patient has a hypo-autofluorescence lesions in the foveas, which this is compatible to geographic atrophy. And here we see spectral domain OCT with the horizontal cuts on the fovea. And based on the findings of the hypertransmission defects, we can conclude that the patient has a complete retinal pigment epithelium and outer retinal atrophy. So the visual acuity in the left eye, it's finger counting from 2 meters, and the visual acuity in the right eye is 0.32. The question here is how to treat this patient. Is there any medication? And currently the only available, let's say, is Pegcetacoplan. Will you consider this? What are your thoughts? The next case, the second one, was retrieved from the Japanese Journal of Ophthalmology, and it's about a 72-year-old male patient with right eye polypoidal choroidal vasculopathy who received 20 injections of Eylea and still had some subretinal fluid. And then it was decided to try a different anti-VEGF. One day after the injection, the patient presented with corneal folds, hypopyon, and severe vitritis, a quite unusual presentation. The intraocular inflammation was due to the injection of Brolocizumab. 5 days after the injection, there was a significant impact on the subretinal fluid, though. So with this being said, today I will provide a brief overview of AMD and discuss the FDA-approved medications that produce good results in clinical trials, but later on have led to adverse events in patients with different types of AMD. So let's start. AMD is one of the most common causes of irreversible vision loss worldwide. And this is a huge problem. In the United States alone, approximately 11 million people have AMD. And it was calculated that from 17,000 blind certificates registered throughout the decade in Israel, AMD was the primary cause. So the pathogenesis of AMD is a complex interaction of unmodifiable and modifiable risk factors. Age is, of course, the greater risk factor, and the risk of AMD increases exponentially with age. The risk of developing AMD and progressing to advanced AMD are highly influenced by genetics, with a great focus lately on the complement system. And finally, your lifestyle and your environment, like smoking and diet are all involved in the pathogenesis. So there are different stages of macular degeneration, from no macular degeneration to early AMD, and then to intermediate. And the intermediate stage is really important to us, the ophthalmologists, because we recommend using the RX formulation. And the late stage AMD can take two forms: the dry or geographic atrophy, now known also as C-RORA, and the wet AMD or the neovascular. So what is the best way to treat geographic atrophy? And the single best answer here is there is no treatment. And don't forget that RX vitamin supplementation reduces AMD progression by 25%, but they don't prevent geographic atrophy. And currently, there are multiple areas that are testing for AMD treatment, but the area of greatest research is suppressing inflammation through complement modulation. So our body activates the complement cascade in 3 ways, with the most active being the alternative pathway. This pathway hydrolyzes C3 to C3a and B to protect us from pathogens. But overactivation of this pathway can lead to excess phagocytosis, inflammation, and cell lysis, which all contribute in geographic atrophy. And you can imagine that by blocking C3, it blocks all three activation pathways, which is the target of Pegcetacoplan. So our department participated in the DERBY and OG study by Apellis, which involved the use of Pegcetacoplan on a monthly or bi-monthly basis compared to a sham. The study was conducted on patients with geographic atrophy, and the primary objective was to prevent the growth of geographic atrophy. And the study results were highly promising. The gray bars present the sham patients, while the blue and the orange bars show a significant reduction in geographic atrophy. And Professor Ursula from Vienna, Austria, created a demonstration illustrating the difference in RPE and photoreceptor depth between the study eye and the fellow eye, with a dramatic decrease in growth in the study eye compared to the fellow eye. So the results were huge, and you can imagine everyone was enthusiastic about them because currently there is no medication, and this could be the only possibility. Moving on, the side effects of intraocular inflammation and endophthalmitis were found to be similar to the rest of the anti-VEGF agents in the study trials. Pegcetacoplan had two emerging side effects. One, the choroidal neovascularization or exudative AMD, and the second one was the ischemic optic neuropathy. So the risk of choroidal neovascularization was higher in patients receiving monthly treatment to 12% compared to the other groups. So basically, this means that some patients who initially had dry AMD developed wet AMD after treatment, which now requires like 2 injections. Then there is a hypothesis regarding this occurrence of choroidal neovascularization, and it is provided by Dr. Speth, which suggests that the complement system's job is to eliminate damaged cells. If the complement system is inhibited, it may slow the progression of geographic atrophy. However, these damaged cells also secrete vascular endothelial growth factor and other cytokines, and their presence could explain the reason of increased choroidal neovascularization. Nevertheless, Pegcetacoplan received FDA approval on February 2023, with over 200,000 injections administered to date. But after the FDA's approval of the medication, 32 patients reported intraocular inflammation following Pegcetacoplan injection. Additionally, vasculitis occurred in 14 patients, with 79% of them experiencing occlusive retinal vasculopathy. And all of these cases were observed after the patients received the initial injections. Now, the cause of the condition is still unknown, but Pegcetacoplan works in a unique way by inhibiting the complement pathway. Now, patients with deficiencies in complement components may display symptoms similar to systemic lupus erythematosus caused by immune complex disease. And therefore, the injection of Pegcetacoplan affects the eye's complement systems, and it may theoretically increase the risk of immune complex aggregation, the vascular damage, and lead to inflammatory disorders. It is also possible that inflammation can occur due to impurities in the manufacturing process. And another cause could be the interaction between the syringes, needles, and the drug. Apellis Pharmaceuticals reported that internal structural variations were identified in the 19-gauge filter needle, and therefore they now recommend using the 18-gauge needle. Moreover, pre-existing or treatment-induced anti-PEG antibodies can be another factor. PEG is a molecule used in many products to improve pharmacokinetics. Many individuals may have already developed anti-PEG antibodies, which can cause an immune response or hypersensitivity reaction when exposed to PEG again through pegcetacoplan. And consequently, the European Medicines Agency reported that Syfovre, despite slowing the growth of geographic atrophy lesions, did not provide any clinical significant benefit to patients. Additionally, regular injections into the eye carry a significant risk of adverse events, making it a safety concern. And therefore, many ophthalmologists are now hesitating about using this medication. Now, let's switch gears to the neovascular form. And the neovascular AMD is treated, as we all know, with the anti-VEGF drugs like bevacizumab, ranibizumab, and aflibercept. There are different protocols like treat and extend, prorata, and monthly injections. And we can all agree that the biggest challenge so far is the burden of the injections required for treatment. Brolocizumab is a molecule that inhibits all isoforms of VEGF-A, and in contrast to the rest, it has the smallest molecular weight. This helps the molecule to be delivered into the vitreous at molar doses much higher than previous anti-VEGF drugs and penetrate deeper under the RPE and act for a longer duration of time. Now, the Hogue and Harrier pair trials compare the effectiveness of brolocizumab versus aflibercept injections, and the results of the study were quite remarkable. Patients who received brolocizumab demonstrated improvements in vision that were non-inferior to aflibercept. And moreover, over 50% of patients achieved an interval of every 12-week dosing. Brolocizumab was found to be an excellent drying agent and a statistically superior drying agent to aflibercept, requiring fewer injections, and therefore it was approved by FDA in October 2019. But then, following the launch of the medication, the Independent Safety Review Committee concluded that in 50 eyes treated with brolocizumab, the intraocular inflammation was definitely or probably related to the study drug. In contrast, the intraocular inflammation developed in 1.1% of aflibercept-treated patients. And the intraocular inflammation ranged from peripheral vasculitis to occlusion of large retinal arteries. And later on, several articles have reported a high incidence of intraocular inflammation, including vitritis, vasculitis, and retinal hemorrhages. Now, there have been a speculation that the formation of brolocizumab immune complexes, which are created when the body produces anti-drug antibodies, may cause a type 3 hypersensitivity reaction with a subsequent inflammation and vasculitis. Brolocizumab immune complexes are also believed to induce a platelet aggregation and activate T cells, leading to type 4 hypersensitivity reactions. And last, another theory is that there is a Th1 and Th2 cytokine imbalance. And this is because a group of patients with intraocular inflammation had significantly higher serum metalloproteinase 9 levels and a lower proportion of plasma Th2 cells when compared to the group with no inflammation. And therefore, almost no one is using this medication anymore. And last, moving to Faricimab, which is a novel drug that inhibits both angiotensin II and VEGF-A, resulting in sustained efficacy. The recent approval of Faricimab as Vabysmo by the FDA was based on the positive results of Tenaya and Lucerne for treatment of wet AMD after 1 year. And this was exciting news for the medical community. And very recently, the results of the 2-year follow-up study have also been published. So at last visit, both Tenaya and Lucerne trials showed that Faricimab resulted in non-inferior visual outcomes compared to aflibercept, with fewer injections needed. And these pie charts indicate that Faricimab molecule demonstrates strong durability, as 59% of patients in the Tenaya group and 67% in the Lucerna group achieved intervals of every 16 weeks. And like all anti-VEGF injections, Faricimab may have potential risks. However, the study showed that the proportion of patients experiencing any intraocular inflammation in general was low and similar to the aflibercept group. But then, in November 2023, Genentech issued a letter to healthcare providers due to post-marketing experience of the risk of retinal vasculitis with a rate of 0.17% per 10,000 of injections. And according to a case series report from Johns Hopkins University Hospital, from the total injections given within a month, 3 patients in the Faricimab group experienced severe intraocular inflammation. And this translates to an event rate of 1.6%, which is significantly higher than the reported incidence in other anti-VEGF types. And this is an example where the patient presented with hypopion, vitreous opacities, and intraretinal hemorrhages. And at last, the events were judged unlikely to be coincidental or due to unknown handling or storage problems. And as we have seen with previous anti-VEGF medications, there is a possibility that the drug may cause the development of Faricimab antibodies in around 8 to 10% of cases with subsequent inflammation. And additionally, during the manufacturing process of the agent, protein aggregates of the drug may cause silicone oil to be released from syringes, which can lead to an inflammatory reaction. So overall, we have seen 3 drugs against different types of AMD, the Pegcetacoplan, Brolocizumab, and Faricimab. They all received FDA approval after displaying promising results in trials. However, once put into practice in the real world, concerns were raised regarding their safety due to intraocular inflammation. As a result, their use has been met with hesitation. And the question that arises here is, what could have gone wrong in these trials? And this leads us to an open discussion